Good afternoon, everyone. We will get started in just a few minutes. Good afternoon. Thank you for joining early. We will get started in just 2 more minutes. Thank you. Okay, well, good afternoon, everyone. We're going to go ahead and get started in this week's session of a certified revenue cycle representative. And this week, we're going to be covering units 2, specifically 2.1 to 2.3. We're still in that pre-service part of the cycle. And units 2.1 to 2.3 will go over types of patients, scheduling, and pre-registration. Once again, my name is Natasha Caballero, and I am one of the committee members for the certification committee for the Florida HFMA. For today's session, we're going to be focusing, as I mentioned previously, on these pre-service functions, and these are critical functions to get right from the get-go. So anything that happens or that doesn't happen in these sections on this part of a cycle usually affects the revenue cycle process downstream. As a reminder, please make sure that you are signed up onto your learning with an HFMA and that you review these modules before the next week's call. And it's important that you follow up and that you complete these as we're going along so that you're getting the best of your learning. There's a significant amount of information that we cannot review during this session. So it's important that you go in and that you learn on your own. You can always jot down questions if you need to follow up in next week's or whatnot. There's also no expectations that just attending these sessions will allow you to pass the CRCR. You will need to do your homework and do some self-studying as well. So for section 2.1, covering types of patients, we're going to identify different types of scheduled and unscheduled patients within an acute healthcare facility. And we're also going to look at non-acute patient types. Types of patients. So we have scheduled, unscheduled, and non-acute types of patients. A patient's first contact with an acute healthcare facility, it's either a scheduled or unscheduled patient, depending on whether immediate care is needed or if the services can be scheduled for a future date or time. Many patients receive healthcare services that are not scheduled ahead of time, including urgent, direct admit, walk-ins for routine labs, x-rays, and newborns. There are several health services available to patients which are not normally provided in an acute hospital setting. And these include the skilled nursing, hospice care, home health services, clinic services, and durable medical equipment. So for scheduled patients, we can also break this down further. You have scheduled inpatients, scheduled outpatients, scheduled recurring series patients, etc. So patients are considered scheduled if the healthcare facility knows that this patient is coming ahead of time. Healthcare facilities normally schedule services that are high dollar and require significant pre-processing to ensure appropriate reimbursement and/or significant resource coordination. Scheduled patients can be registered as inpatients, outpatients, or recurring series patients, as mentioned previously. And typically, recurring patients are therapy series patients, behavioral health, chemotherapy, and radiation therapy. Patients are scheduled as inpatients if the level of care meets inpatient acuity criteria. Most facilities use Medicare standards as the guideline for determining inpatient status. Major surgery patients and obstetrical patients are the most commonly scheduled as inpatient. Direct admit patients can be considered scheduled if a physician calls the facility ahead of time to let them know if the patient is coming. And we're saying call, but I'm sure that there are other contactless or electronic processes where physicians nowadays don't need to call anymore. Patients are scheduled as outpatient if the service they receive do not involve an overnight stay. Patients arrive for service, receive the treatment or testing, and then go home. Examples of these could be routine diagnostic testing, like an X-ray or an MRI, for example, pulmonary function testing, interventional radiology, ambulatory surgery, and labs. Certain services where the treatment is ongoing are registered as recurring or series patients, and these could also be considered outpatient. Once the registration is completed and the charges related to that ongoing treatment are entered on one account for multiple days or services, then that can be billed. They can typically be registered or re-registered on a monthly basis if the treatment duration exceeds 30 days. Examples of this could be the therapies, the behavioral health, IV therapy, chemotherapy, and radiation therapy. Unscheduled patients. And so here you have some examples of what the unscheduled patients are. The emergency department is the most common source of unscheduled admissions. Patients arrive at the ED seeking care, and if the patient meets acuity criteria for that admission, an order is written to admit the patient. When the patient is admitted, the admission will be considered an emergency admission. Most health plans require a notification of emergency admissions within a specific time period, and it's usually 24 hours or just the next business day. Failure to do this may result in denials at times, or denials of some of the days. Certain types of services, such as routine X-rays, laboratory tests, are typically provided without the benefit of prior scheduling, and they could be considered as walk-ins. Typically, these services do not require an approval from the health plan, but may require that the patient be seen in a contracted or in-network facility. Observation is used to evaluate patients for possible inpatient admission, to resolve a medical problem so that the patient may be discharged afterwards, for treatment that is expected to last less than 24 hours, or also to treat complications following an outpatient surgery or procedure. Remember the Medicare 2-night rules as it relates to observation patients. Non-acute types of patients. And so here you're looking at your skilled nursing, hospice care, home health services, etc. patients admitted into a skilled nursing unit or facilities, and we will call these SNFs, when they no longer meet the criteria for acute care, but still need an inpatient level of skilled nursing care or rehabilitation services. These usually include orthopedic surgical patients who require intense physical therapy and stroke patients who require a comprehensive rehabilitation service. Typically, Medicare will only cover these services in a skilled nursing facility if the patient was transferred after at least 3 days of inpatient stay for a related illness or injury. We know that with the pandemic, some of these restrictions were removed to facilitate care. However, the regulation has not been permanently changed. Hospice care is intended to provide humane and compassionate care for patients who are in the last stages of an incurable disease and have a life expectancy of 6 months or less. Hospice services support the patient with pain relief and symptom management, but the disease is no longer treated. If a hospice patient receiving services on the Medicare program is admitted to the hospital for hospice-related services, the hospice program is billed, not Medicare. Home health services can be covered or can cover a wide range of healthcare services, which can be given in a home for an illness or an injury. And these could be things like physical therapy or speech pathology, for example. Next, medical equipment is deemed durable medical equipment if it's intended to be used over and over again. And so examples of these can include wheelchairs, hospital beds, oxygen tanks, etc. Finally, a clinic is a facility or part of one that is devoted to the diagnosis and treatment of outpatients. And some key points for this section: patients are considered scheduled again if the healthcare facility knows that this patient is coming ahead of time. Scheduled patients can be registered as inpatients, outpatients, recurring series, patient types. Many patients receive healthcare services that are not scheduled ahead of time. These patient types include unscheduled inpatients or urgent patients, unscheduled outpatients or walk-in patients, also emergency patients, observation patients, and newborns. Also, non-acute health services include skilled nursing, hospice care, home health services, clinic services, and durable medical equipment. And lastly, hopefully in this section, we've given you some idea of the various types of patients you can encounter and the importance of scheduling patients to ensure appropriate resources are secured. And so that brings us to our first polling question of the day. And that is, which patients are considered scheduled, or which patients are considered scheduled to be scheduled? And we can go ahead and close that out and share the results. And yes, number 1 is correct. Patients who receive services where the treatment is ongoing or registered as recurring or serious patients and are categorized as scheduled. Services for scheduled patients are high dollar and require significant pre-processing to ensure appropriate reimbursement and or significant resource coordination. So great job, everyone. Second question, how many days must a patient be inpatient for Medicare to pay for the skilled nursing facility? And we're gonna fire that polling question. There it is. And let's end the poll and show the results. And number 3 is correct. Again, changes to this during the pandemic. We saw these changes during the pandemic and other things were allowed, but the correct answer is still 3 days. And that brings us to Unit 2.2, scheduling. So we're halfway through our session today. And in this section, we will be addressing scheduling processes, including patient identification, requested service, medical necessity screening, and the Medicare Advanced Beneficiary Notice. Scheduling key concepts. Scheduling patients for service allows the facility to prepare for the patient's service by reserving time and obtaining information, equipment, and resources required to provide the service. It also shows the facility the time to review the appropriateness of the service, screen for managed care requirements, and resolve any financial issues prior to service. Completed daily schedules are used by the service department and the arrival area if the patient does not go directly to the department to complete final preparations for that patient's arrival. And each component of the scheduling process will be discussed in some detail during the CRCR course or in your study materials, as these activities form the basis for pre-service registration and final processing. Core concept steps, we have patient identification, requested service, scheduling instructions, review and validation, patient reminders and arrival instructions, as well as order requirement. And so we're going to be going over first the scheduling process, specifically as it relates to patient identification. And so this is the first and most important step in making sure that we obtain the right information and we ensure that we have the right person in front of us to for their safety and security, and for us as well at the facility level. And so this first important step in scheduling is identifying who that patient is and making sure that we have the right record in front of us. Healthcare information systems maintain historical databases for every patient who has had services within that healthcare system. Critical patient information, including the patient's full legal name, date of birth, sex, and social security number, is collected and used as patient identifiers. Each patient is assigned a unique number commonly called the Master Patient Index Number, or MPI number. It could also be called the Corporate Patient Index Number, or CPI number. Individual episodes of care are linked to the MPI or CPI number to enable the provider or facility to identify all services provided to an individual patient within that healthcare system. When there is a request for service, the scheduling staff must confirm the patient's unique identification record to ensure that she or he has accessed the correct information in the historical database. Obtaining and confirming accurate patient information is extremely important in order to avoid data errors such as duplicate medical record numbers or choosing the wrong patient. Once that correct patient is identified, remaining demographic information is obtained and or validated and updated as necessary. Excuse me. The following is a list of typical demographic information. And we have the full patient's legal name, the date of birth, patient social security number, patient sex, marital status, complete address, telephone numbers, race, occupation and employer, and also the name, address, and telephone numbers of emergency contacts or next of kin. And if you look at this list, it's important that we highlight the first item here, full patient legal name. And so that is the name as recorded on that government ID, which is usually the driver's license or that state ID, but it could also be a passport, or anything else that is government issue. It can also be a court order if it's someone that recently changed their name. So a patient may want to be called something else, and we usually do not advise in using those preferred names as their legal name. It's important that you stick to whatever's on that government ID, and perhaps you may have a field that is a preferred name if the patient would like to go by something else. A physician order is generated and becomes the basis for the request or that service. The contact for the request for service can come from the patient, the physician's office, or the service department within that healthcare facility. If a patient is scheduling the service, he or she is given a written physician order, or the physician's office faxes the written order to that scheduling department and is asked to call and schedule the service when it's convenient for the patient. Patients usually schedule services such as ultrasounds, mammograms, stress tests, and therapies, and the physician's office typically schedules surgery cases, catheterizations, and other invasive type procedures. The type of requested service will determine the scheduling instructions. Instructions to the schedulers range from basics, such as the amount of time needed for that test, to the complex, when rooms or additional equipment or personnel must be coordinated in order to provide that service. Many healthcare organizations use automated scheduling systems and build the scheduling questions within the system already. And the scheduling system prompts the scheduler to complete the required scheduling instructions each time a test or a procedure is requested. If an automated scheduling system is not used, a binder including all scheduling instructions should be maintained to facilitate the scheduling process and ensure all critical instructions are completed. And I would add are completed every single time for consistency. One example of scheduling instructions would be for when scheduling a nuclear medicine procedure, the contact department in order to isotope, reserve a procedure room for X amount of minutes, inform the department if the patient is in a wheelchair, and provide medication instructions based on the type of test order. Scheduled procedures routinely include patient preparation instructions that must be completed prior to the test or procedure. By providing accurate instructions during the scheduling process, the scheduler ensures that the patient will properly be prepared for that service. Examples of commonly used patient instructions include refraining from eating or drinking anything after midnight, taking all prescription medications on the day of the test, at least 90 minutes prior to the examination, drinking 24 ounces of water. Before finalizing the scheduling contact, all components of the scheduling contact must be reviewed and validated. This is an important step to verify that the patient has a complete and accurate information. The following information should be reviewed as part of the schedule finalization. And these are, but are not all-inclusive, so it could there could be other things depending on the test and the facility. The service to be scheduled, the date and location of the scheduled service, arrival time and procedural time, verifying that patient is clear on the scheduled time, the test time versus the required arrival time. Required pre-service testing, including completion and time frame, and patient preparation instructions, as well as arrival instructions, such as where to park, where to report to, and how to get to that service area. The patient reminder is a written list of the patient's responsibilities, and it's usually included and summarizes at the end of the scheduling call, along with any additional instructions provided as part of the additional access processing activities. And so these could be required insurance forms, expected time of service payments, etc. Reminder letters can also include maps that show the patient where to park, where to report to when she or he arrives, and where the service department is located. These notices may be used to reduce the incidence of no-shows or no compliance within testing instructions. Many facilities call the patient a day or two prior to the scheduled visit to remind them of that appointment. Review and validation. So before finalizing the scheduling contact, all components of the scheduling contact should be reviewed and finalized. This is an important step to verify that the patient has completed and has the accurate information. The listed information should be reviewed as part of the schedule finalization. And so we've already gone through some of these. I'll leave it up there for one moment for you to review it once again before we move on to the next slide. Okay. Patient reminder and arrival instructions. A patient reminder is a written list of patient responsibilities and usually includes the same itemized items summarized at the end of the scheduling call, along with additional instructions as part of the access processing activities. And we sort of talked about these already and how these include health plan forms, payments, etc. Notices may be used to reduce the incidence of no-shows and non-compliance, as previously mentioned. Order requirements. Tests and services can only be provided with a valid physician order. A few exceptions are the requests from Medicare beneficiaries for flu vaccines, pneumonia vaccines, or screening mammographies. Initially, verbal orders can be taken as long as they are accepted by qualified staff as defined in the facility's medical staff bylaws, rules, and regulations. All verbal orders must ultimately be authenticated by the ordering physician by subsequent written signature, fax signature, or computer signature. Medicare requires the following data elements to consider a physician's order to be valid. And these are the patient's full legal name, the date order written, or so the date that order was written, test or service ordered, the diagnosis, coded diagnosis, or narrative description of the reason for the test or service, the name of the ordering physician or allied health professional, or AHP, signature of the physician, or AHP ordering the test of service. Orders may be written on a prescription pad, documented, pre-printed form, or electronically generated and transmitted by the physician's practice's computer system. And these orders must include the physician address and telephone number, the MPI number, the patient's date of birth, the patient's sex, patient's social security number, patient's demographic, and health plan information. Medicare medical necessity screening and ABN processing. So Medicare will only pay for tests and services that it determines are reasonable and necessary. Medicare has established guidelines called the Local Coverage Determinations, or LCD, and National Coverage Determinations, or NCD. And these establish which diagnoses, signs, and/or symptoms are payable. If a test is ordered where an LCD or an NCD exists, there must be documentation if a medical necessity in order for Medicare to pay for that test or service. If a test or service is not medically necessary according to that LCD or NCD, a signed advanced beneficiary notice, or commonly known as ABN, must be obtained from the patient. An ABN is not used for inpatient services or for tests that are always excluded from Medicare payments, such as acupunctures, experimental tests, and research testing. Medicare provides other forms for these situations. The purpose of an ABN is to give the patient advance notice that Medicare may not pay for the test or service ordered and the associated cost, which will be billed to the patient. The ABN must be issued to the patient before providing services related to that ABN. Generic, routine, and blanket ABNs are not acceptable except in cases such as frequency limitations where all patients may be at risk. Hospital-issued notice of non-coverage. An ABN is not used for inpatient services as mentioned. The inpatient counterpart of an ABN is the HINN, and so this is a hospital-issued notice of non-coverage and should be provided for beneficiaries prior to the admission, at admission, or at any point during that inpatient stay, if the hospital determines that the care the beneficiary is receiving is about to receive is not covered. And some key points for this section. Medicare has established guidelines called Local Coverage Determinations, LCD, and National Coverage Determinations, NCD, that are used to determine which diagnoses, signs, or symptoms are payable, and tests and services can only be used with a valid physician order. And another point to keep in mind is that key patient information, including the patient's full legal name, date of birth, sex, and social security number, are collected and used as patient identifiers. And this brings us to our next polling question. Name the guideline that Medicare established to determine which diagnosis, signs, or symptoms are payable. We can go ahead and close that polling question and show the results. And you were all correct. Number 2 is the right answer. Medicare and other health plans will only pay for tests and services that are determined to be reasonable and necessary. Medicare has established guidelines called the Local Coverage Determinations and National Coverage Determinations. So great job, everyone. And coming up on our last section, 2.3, we're going to talk a little bit more about pre-registration, and specifically the purpose and process of pre-registration, information collected during this part of the process, consequences that an organization may experience due to inaccurate or incorrect patient information, as well as an overview of the Medicare secondary payer screening process. Pre-registration should be completed for all scheduled patients prior to their arrival for service. Obtaining the patient's demographics and insurance information prior to the service is one of the key steps to ensure accurate and timely billing. A best performance indicator is that of 98% for all scheduled patients that should be pre-registered. So again, 98% of all scheduled patients should be pre-registered. A successful pre-registration program also identifies the potential need for financial assistance and provides staff with the opportunity to give patients preparations instructions. The process for pre-registration ensures that the patient access staff will have completed and have valid information needed to finalize any remaining pre-access activities. And these include the MSPQ, or Medicare Secondary Payer Screening, medical necessity screening, insurance verification, pre-certification and authorization, managed care requirement solutions, and financial education and resolution. And I believe the most important benefits is that the patient have taken care of the financial issues and concerns and can focus on their tests or treatments during the visit. So it's important to do these things ahead of time. So we just see a picture here, but I'm going to tell you a little bit about data collection. And so the purpose of the initial pre-registration step is to identify if a patient has been a previous patient and has had an existing master patient index number. And so remember how we talked about this number and that this is unique to each patient. And so it's important that when we are obtaining the information, and especially in areas that are highly populated, for example, I live down in Miami, there may be a lot of patients with the same name and date of birth. So you may have to resort to other key data elements to make sure that you have the right person in front of you, to avoid selecting the wrong record, and also to avoid creating duplicate records. MPI and data collection. The first critical step for all patients arriving for service, scheduled or unscheduled, is to verify the identification. Express check-in should be established for scheduled and pre-registered patients, either in a designated area or within the service department. Because pre-service processing has been completed, the only registration steps include confirming positive patient identification, activating the record, placing an armband on that patient for the correct service, and obtaining signatures and finalizing any financial resolution obligations. For patients with no MPI, a new medical record will be generated, and the required information include the full patient's legal name, minimum requirement of sex, also known as gender, the date of birth, and additional information includes the race, ethnicity, social security number, etc. Consequences of improper data collection. And so as we see here, this can lead to wrong medical history, billing information not being correct or accurate, and just incorrect medical record altogether. Serious consequences may occur if patients are identified incorrectly via the generation of a duplicate medical record or by selecting the wrong patient record. Treating a patient for the wrong medical history can have a serious adverse reactions to treatment to that patient, since we don't know if that patient has allergies or whatever the case may be. In the case of the wrong procedure, you can only imagine what that may lead to if we're doing so in the wrong patient. If insurance information is wrong, then a patient claim is sent to the wrong health insurance. Explanation of benefit statements then are sent to the wrong patient and resulting in a serious breach of confidentiality and is considered erroneous billing. And incorrect medical services are added to the wrong patient medical record, potentially perpetuating adverse medical outcomes. Insurance information or verification. Once a registration process is completed, insurance verification is conducted to ensure the accuracy of insurance information. Coverage issues are identified and communicated to the patient. This sets the stage for completion of financial education and account resolution based on deductibles, co-insurances, and other coverage limitations. Insurance verification can be completed through electronic inquiry or telephone contacts. Most major health insurance payers, including Medicare and Medicaid, offer electronic verification via the ANSI, and that's ANSI 270/271 transaction set. Electronic inquiry provides the fastest and most cost-effective and efficient way to complete insurance verification and should be used whenever available. Electronic verification may be automated through the registration system or initiated manually via the payer's website. Sequencing plans involved in a coordination of benefits, or COB, situation so the primary, secondary, and tertiary plans are correctly recorded and billed. Recording patients' out-of-pocket liabilities such as deductibles, coinsurances, and copayments, and other coverage limitations allows for more accurate estimates of the amount the patients may owe. And identifying the pre-authorization and pre-certification requirements based on the patient's plans, service, or location are key to ensure and avoid any back-end denials that may have a limited capability to be overturned. Medicare secondary payer screening. For Medicare patients, it's an important component of the pre-registration process is to have the effective completion of the Medicare secondary payer or MSP screening process or questionnaire. The basic MSP rules are discussed in the course in 1.6 Medicare and Compliance Regulations. For patient access staff, understanding both the MSP rules and how to ask the MSP questions are essential. Many facilities have developed computerized MSP forms that guide the staff through the required questions. This is another topic that is repeated in a few sections, so understanding the MSP rules would be very important. Anyone who has worked in a patient access area or department will tell you that patients don't really understand this process or these questions. And so it's very important that when we're asking these questions, we're asking the patients and allowing them to answer these questions and not assuming what the answers may be. And so some of the details for this questionnaire, for example, if a patient or spouse is working and is over the age of 65 and has chosen to take the group health plan, and they don't have to, they could be offered as supplemental, and the employer for that group health plan has more than 20 employees, then that group health plan is primary over Medicare. If a patient is under 65, the age of 65, has Medicare through disability, and has a group health plan where that employee has more than 100 employees, then that group health plan is also primary over Medicare. If the patient has a Medicare through the end renal stage disease and has a group health plan, and then the group health plan is primary during the first 30 months of that coordination period. Once they have met the 30-month coordination period, Medicare then becomes the primary payer. And lastly, if the patient has a liability coverage due to either an auto accident or workman's compensation premise accident, then the liability coverage must be filled first or must be billed first. If a patient has an accident in their own home, the liability would not apply and Medicare would then be primary. Incomplete pre-registration. And so insurance denials can occur for incomplete pre-registrations or when some of these things may be missing. And some of these items include missing or invalid subscriber information, being ineligible on a specific date of service that's being billed, authorization requirements, out-of-network status, medical necessity failure, and coverage limitations. Cost of a denied claim. The average cost to rebill a claim, if you can, is $50 per claim. When the claim is reworked, analyzing the denial, requesting additional information, reviewing notes and documentation, appealing the denial, preparing and resending the claim. So these are all the steps in working that claim or reworking that claim. The amount earned is dramatically reduced. So just think about all the work that has to be put in if you want to appeal a claim, and how important it is to get it right the first time, so that you're not reducing the amount that you're earning on each of those claims. And these are some key points for this section before we get into our last two polling questions. Properly completed pre-registration ensures that patient access staff will avoid the following issues: return mail, impacting the ability to contact the patient, to collect self-pay amounts, also insurance denials for missing a list of things here that we just talked about, such as coverage limitations, not having coverage on a specific date of service, etc. And also, unnecessary health plans follow-ups and rebilling could be avoided. So this is our next polling question, and we're almost done. What is the purpose of insurance verification? So go ahead and take a moment to answer that. All right, so we can go ahead and call it. And this was a tricky one. And most of you put to ensure the accuracy of the health plan information, as you can see there. However, we feel that number 4, which is the one you all chose. I'm sorry, I was looking at this incorrectly. That is the right answer. And during this process, coverage issues are identified and communicated to the patient. Insurance verification sets the stage for completion of financial education and account resolution based on deductibles, coinsurance, and other coverage limitations. And the final polling question and final slide for today: when is Medicare not a secondary payer? And remember, we went through some of those examples. So just take a moment to read the different options and select which one you feel is the best answer. Okay, so we're gonna share the results. And the answer here is actually number 2. Accidents in the home are not covered under liability, and Medicare would be the primary payer. And with that, we have come to the end of our session. Does anyone have any questions? Remember, these recordings will be available on the YouTube channel. And you should, if this is not posted right away, you for sure will find previous recordings for this same section. So you can use that to follow along in your studies as you're going through this section. And again, we recommend that you do that before you join us in our next session next week. And so I don't see any questions here. So we want to thank you for joining us today and wishing you a good rest of your week. Bye-bye. Thank you.